Good morning. I am here to present my paper on the topic Visual Outcome and Complications Following Retrofixated Iris Glow IOL Implantation in Patients aged 40 to 80 years in a tertiary center in northern Kerala. I have no financial interests. So the aim of modern cataract surgery, as we know, is to leave the patient with a good pseudophakia, but in some cases, when things go south, we may have to do an emergency exit and adopt special methods of IOL implantation. So iris glow lens is on the rise as a secondary IOL, and compared to its counterparts like anterior chamber IOL, it has a lower risk for endothelial and trabecular meshwork damage. And also compared to scleral fixated IOL, it is technically less challenging and has a shorter learning curve. So the aim of my study was to assess the visual outcome and complications of retrofixated iris glow IOL to correct aphakia. So this was a hospital-based retrospective study, and the patients included those who were aged 40 to 80 years who underwent either primary or secondary retrofixated iris glow IOL implantation from January 2019 to January 2023. 55 eyes of 55 patients were included. The study setting was Tertiary Health Center in Northern Kerala, and the outcomes were analyzed at postoperative day 1, at 1 week, and at 1 month. So those patients with surgical aphakia with insufficient capsular support where posterior chamber IOL implantation could not be possible were included. Patients with any gross iris abnormalities like anaerodia or rubeosis iridis, traumatic mydriasis, any other retinal pathologies like diabetic retinopathy, glaucoma, and those with decompensated corneas were excluded. So the preoperative and postoperative assessment included uncorrected and best corrected visual acuity using Snellen's chart, a slit lamp examination, intraocular pressure measurement, fundus evaluation. And all the data were entered in MS Excel sheet and analyzed using an SPSS software. So the results of the study, of the 55 eyes of 55 patients, it was done as a primary procedure in majority of the cases, 85.4%, and as a secondary procedure in 15.6% of the cases. And majority of the patients were of the age group 61 to 70, that is 58.2%. 60% of them were male patients and 40 were female. And the preoperative best corrected visual acuity was 6/60 or less in 76.3% of the patients, whereas the postoperative 1 month best corrected visual acuity was more than 6/18 or more in 67.3% of the patients. So according to the WHO classification for visual acuity assessment following cataract surgery, this comes under a good visual outcome. And the mean preoperative IOP was 16.3 plus or minus 3.1 millimeters of mercury, and there was and post-op mean IOP was 17.3 plus or minus 3.2 millimeters of mercury, and there was no significant rise in postoperative IOP noticed compared to preoperative IOP. There were no cases of persistent corneal edema at post-op 1 month assessment. And the most common postoperative complication encountered in my study was iris atrophy, noticed in 13.9% of the eyes, and hyphema was noted in first postoperative day in one eye, which resolved with medical management. There was one eye which had haptic disenclavation, which required a resurgery to do re-enclavation, and 11 eyes had pupillary distortion postoperatively. No major complications including raised IOP, chronic anterior chamber inflammation, bullous keratopathy, cystoid macular edema or retinal complications were noted. So we concluded that the retrofixated iris glow implantation had a good visual outcome and complication profile, and since there were no other ocular comorbidities, it was a direct reflection of lens implantation, and it is a cost-effective method. It provides good visual rehabilitation, has a shorter learning curve, and takes a less surgical time. These are my references. Thank you.
So this was retrofixated iris claw lens, right?
Yes, ma'am.
So what were the parameters that you, preoperative investigations that you did before you planned an iris claw lens?
Visual acuity, both uncorrected and best corrected, IOP assessment with non-contact tonometry, then anterior chamber anterior segment examination, slit lamp assessment.
How was the AC depth analyzed, anterior chamber examination analyzed?
Anterior chamber slit lamp examination with von Herrich's grading was done.
That was done, okay. So this was, you had two groups, right? Primary surgical aphakia and secondary.
Yes.
So in patient primary, of course, you cannot do, but in secondary aphakia, did you do a gonioscopy? Was an endothelial count done?
No, ma'am.
See,
That
that's
is
the
a
major
drawback.
drawback of
Yes,
your
ma'am.
study,
Yes, ma'am.
because your study follow-up is 1 month, right?
Yes, ma'am.
So that's too short to really know is there any endothelial damage. So that can be probably included, because all these things is okay at 1 month. So what happens in the long run with the because iris is extremely inflammation generating tissue. Okay, so we don't know how it is going to react. So 1 month, and what is the other problem? 1 month you are going to give steroids. Your patients will be on steroids for at least 4 to 6 weeks, isn't it? So once the steroid stops, how is the eye going to behave? That is something that you have to look. So you need a long-term study to know that. And if you can include a specular or an endothelial count in your study, pre and post-op, at least in the group which had secondary aphakia, because in this you're going to do it as a planned procedure. You must know how they behave later. And what was the type of IOL used in your study? Was it the same type of IOL?
Yes, ma'am. Same type
You
of
should mention that, because different IOLs have different types of enclavation, and they have different ways of behavior. So that also makes a big difference. So those things also should be taken into account.
Yeah, I happened to say, second part of presentation only I saw. Why did you choose iris glow? What are the other options?
Anterior chamber IOL and then scleral fixated IOL, because with the literature we know this is an easier method which requires less surgical instruments and shorter learning curve and takes less surgical time. So if this can be mastered by the ophthalmic
Anybody,
surgeons.
yeah, okay. So it's basically the feasibility of doing the surgery. Okay. So what was the follow-up?
Follow-up was done at postoperative 1 day, 1 week and 1 month.
So after 1 month, you have not seen the patient. I'm just asking you. No. Okay.
That should be clearly mentioned. Why did you decide? Because it's not a randomized. See, any study becomes very good and comparable if you have another arm which goes for a second option. Like probably if you compare it with SFIOL. SFIOL is the FDA approved standard treatment for surgical aphakia. Okay, iris claw is not approved because it is thought to have some long-term complications. But increasingly we are doing iris claw lenses. So if you can prove at least in 6 months that it is stable and good and comparable to SFIOL, then your study is really good. So that could be something else that you could look into it. Okay.
Thank you.
And surgical time. So these things you can compare. Surgical time when you're doing an iris claw lens, it also has a learning curve. So those are the things that you could look into it and try to improve.
Thank you, ma'am.